All right, so it's 9:05. Thank you guys and gals for logging in for case reviews for the month of March. We have a lot of cases, so I will be quick on some of these double cases. And as always, this information is confidential. We expect everyone to respect privacy and not to share this information. So for the first round of cases, we have a 72-year-old female. Her initial complaint was that she felt like her face was twitching and that one side of her face just wasn't working properly. She had EMS had appropriate PPE. I'm gonna see if I can make that noise. All right. PPE worn by EMS was appropriate for the situation. She was awake, her airway was open, she was unlabored in her respirations, and that she had a pulse that was present. There was no evidence of bleeding. Her initial vital signs were obtained and immediately upon patient assessment, and notable for hypertension at 169/96, otherwise normal, blood glucose also normal. The past medical history that she was able to provide was that she's had a stroke in the past. She's a diabetic and she has some psychiatric diseases. She was sitting on the couch and she said that she felt this twitching and that this resolved about 2 minutes after it started. Currently, that she is complaining of some right-sided facial numbness. Moving on towards treatment. Vital signs, as we already mentioned, a LAM score was recorded 31 minutes after patient contact. Transport was initiated. Additional information provided was from family members stating that these symptoms actually preceded her arrival at home on the couch, that while she was actually in the car, and that the daughter had said that she does have some psychiatric illness and that they recently relocated to this area from Arizona, or at least the patient did, and that they were having some difficulty in controlling her diabetes, and that earlier that day the patient and the daughter had gone to Peace Health to get some prescriptions, and at that point she wanted imaging of her head but was denied. It was unclear if she actually presented to any medical facility besides the pharmacy. Another set of vital signs were recorded en route to the hospital, and she had a peripheral IV established, arrived at the hospital 45 minutes. So at the hospital, she was worked up for a stroke. They thought that this was more likely to be a TIA versus a seizure. She was not admitted. She was discharged from home, or discharged to home. Second case is a 62-year-old female complaining of numbness and tingling when she smiled. PPE used by EMS was appropriate for the situation. Primary survey notable for she was awake, she was protecting her airway, she had a pulse. Vital signs obtained 5 minutes after patient encounter were significant for borderline blood pressure of 100 by palp, otherwise documented as normal. And the past medical history for this patient included also some psychiatric illness, bipolar disorder, PTSD, schizophrenia, as well as asthma, diabetes, hyperlipidemia, hypertension, hypothyroid. It was later discussed, and I think if I remember correctly, later discussed really only in the hospital encounter that she had a history of seizures. Her past medical history, the history presenting for this patient was that she was on the phone with her counselor, and this was not a telemedicine visit. This was just a phone call, and she noticed that her face felt numb and tingly when she smiled. She had some tremors, and she also had abdominal pain, and she reported that she would have these symptoms sometimes before she was going to have a seizure, but she felt that this presentation was unlike her previous presentations. And about 2 months ago, she had her medications adjusted. A BFAST was recorded within a minute of patient contact. Vital signs, as we mentioned earlier, as well as a LAM score Lamb's procedure, I don't believe the Lamb's score was recorded. And subsequent repeat vital signs, an IV, a blood glucose check, and initiation to the hospital at 29 minutes. And then a couple more blood pressure checks, heart rate, vital sign checks actually, and then arrived to the hospital at 44 minutes after patient contact. So in the second case, she had a National Institute of Health stroke scale calculated as a 7. This is a scale that is 0 up to, I believe it was in the 30s. So 7 is abnormal. They determined that she was not a TPA candidate because her symptoms had been ongoing for more than 4 hours. They thought that this was actually a stroke. And fortunately, because of her vagus nerve stimulator for her seizure disorder, she was not able to get an MRI as it was incompatible. She was admitted to the hospital for stroke care and evaluation. During her hospital course, she had a complication of going into AFib with RVR, and she was discharged on hospital day 6. Per the neurology notes, they thought that this seemed to be, again, atypical for a typical seizure, typical stroke, but they thought maybe this was related to post-ictal paralysis. And the reason why we bring up these cases is to talk about TIAs and what expectations are with our protocols. So TIAs are going to be anything that's a transient, fleeting moment of stroke-like symptoms, usually lasting for only a few minutes. And they're caused because of impairment of blood flow, if that's plaque or if that's clot, and that they can present exactly like a stroke or some other neurological complaints. And like I mentioned earlier, they usually last for only a few minutes, but they can last upwards of 24 hours. Treatment for TIAs are similar to strokes with prompt evaluation, oftentimes goals of less than 60 minutes to assessment, but our goals is to do this faster than that. And then the prognosis, TIAs are no little thing. You may describe it to your patients as well as a baby stroke or as a warning stroke or whatever variation, but these are oftentimes associated. A TIA can be present 12% of the time before an actual massive stroke, and that those that have a TIA, up to 12% of them will actually die within the next year, and that anywhere upwards of 17% of people that have a TIA will have a real stroke or an impaired blood flow that is persistent in the next 90 days. So what happens for these patients is that they get assessed as if they're a stroke, and they look for evidence of vessel occlusion or infarct between CT angio, head, neck, and MRI of the brain, remembering that CT scan of the head is really only helpful for ruling out a bleed. And sometimes you'll pick up a subacute or an early stroke, but it's the angiogram and the MRI that's definitive, and that they look at risk factor modification. So is that they're a smoker, they're a drinker, their diet, is that blood pressure, diabetes, obesity, all of those can be addressed to be modified and decrease the opportunity for a recurrent presentation or worst case stroke. And then oftentimes, depending on what their risk factors are, they will be started on dual antiplatelet therapy. So for the Washington KPIs, key performance indicators for stroke, I listed what our 6 key performance indicators are, and I'll go over them here. So you can see on the left-hand side in the red, for those that might be color impaired, the first 4 is 90% or better. The last 2, number 5 and 6, is 100% of the time expected to be done. So having a fast exam done, having a blood glucose checked, having a less than 20-minute scene time from patient contact and transport if you're suspecting a CVA or a stroke, and documentation of last known, sorry about all the noises, documentation of time last known normal, and sending them to the appropriate stroke center, and also having a fast exam done, the fast exam, but we, as you're aware of, we use the BFAST, so we do additional more than just the fast. And then having a Lamb's stroke scale assessment completed and documented, and if not, why. So I'm not going to go back to those slides, but both of them were not activated as a stroke alert, and both of them had a greater than 20-minute scene time. I know we've been having some difficulties with documenting LAM scores because it comes in the procedure for our meds, but it doesn't necessarily give a score. But I believe that starting April, it will not have to be redundant in our narratives. So, and as a reminder, is that you can see, if you recall from those two examples, the first patient had no neurological complaints by the time hospital arrival, so an NIH score of 0, but the second one had an NIH of 7. So definitely somebody that both of these cases should be activated as a stroke alert for EMS. I think that you may ask yourself, well, what if, so if their symptoms resolve completely with me on scene and I assess them, should I still go as a stroke alert? Yes. If the patient complains of symptoms that were never identified by our EMS providers, that they completely resolve prior to arrival, it's still urgent request to evaluate them, but doesn't necessarily need to be a stroke alert. Dr. Whitwer, are you on the line? Sounds like he's not. If he does log in, we had a conversation about this because of looking.
I am,
Okay.
Jackie. I just couldn't find my on button here.
Yeah, no problem. Do you have anything to add to that?
No. I was out just for a second here, not out, but out of the room for a second, and I'm not having a stroke or a TIA, I don't think. Did you discuss the BFAST as well?
Yeah, well, I discussed it in the sense that we, even though the KPIs for Washington is fast, we are doing BFAST, including balance and I.
Right, and I'm adding, if you've got balance and I positive, I would like that to count as a high level stroke concern also. So that should go to P South Southwest where they can do advanced imaging.
Great. So this is just our protocol, a reminder of our protocol. So assessing if you think the patient has a stroke or another reason for why they're presenting with the symptoms or signs that they're having. Doing a BFAST, as its expectation needs to be recorded and performed. And then also performing a Los Angeles motor scale and documenting the score. And then I'd like to draw your guys' attention to the right-hand side of the screen for H. And then this is for that, sending them to the most appropriate hospital where we are expected to do it 100% of the time. So this is anybody with a LAM score of 4 or greater, older than 80, symptoms more than 3 hours but less than 24 hours. You think that there's a bleed associated with their presentation or they're having a profound presentation. Any one of these would be an indication to send them to PCEP Southwest. All right, if there's no questions, I'll move on to the next. Case 2 is a 43-year-old male complaining of weakness. PPE is appropriate by EMS. Patient was found to be awake. His airway is open. He looked ill. He was pale, cold, diaphoretic. There was a prolonged time to assess vital signs as the patient was non-compliant or uncooperative. Noted to have a blood pressure of 80/42, respiratory rate of 22, while the rest of his vital signs, besides his GCS of 14, were normal. Past medical history is that this is a brittle type 1 diabetic on a pump and has a history of polysubstance abuse. Mom had called because he has been sitting on the floor for the last 3 days. He had used meth and cocaine 1 week prior, and that mom was concerned because he was too weak to get up off the floor. He has had very little to take in. The gallon jug on the right is to represent what was documented of approximately a gallon of emesis in a gallon container, I believe, and that the patient had reported that he was having weakness, fatigue, diarrhea, and nausea. So initially, EMS were very diligent, stayed on scene, continued to convince the patient to allow them to assess him. Eventually, the patient allowed him to be transported. So the first blood glucose came back as E5, and from my recollection, that means it's greater than 700. And then after another 32 minutes on scene, the patient started to allow EMS to start their initiation of treatment. So he was noted to be hypothermic at 96.4, the vital signs that we mentioned in the previous slide. An IV was established, a 12 lead was obtained, and he was initiated to Salmon Creek, code 3. Some of the documentation in the notes is that the patient was very dry. He had dry mucous membranes and cracked lips, and his cap refill was impaired. And noted with his EKG that they felt like it looked more like junctional in the rate of 40 to 50s, and a question of VTAC that self-resolved. I'll go to those 12 leads here in a sec. So, well, I should do it right now. So this is what was thought to be maybe junctional, but the medics were astute to notice that the T waves looked suspicious for hyperkalemia, and with the wide QRS, they started initiation for hyperkalemic management with 5 milligrams of albuterol, 50 milliequivalents of bicarb, and 1 gram of calcium gluconate. Repeat vital signs show that he's just a little bit less hypotensive than he was previously at 90/51, still tachypnic. And they repeated his 12 lead, which for the most part is very similar as the previous, besides the fact that the T waves are not as peaked. All right. So in the emergency room, he received multiple doses of calcium, as well as started on pressors. He had a central line placed. They arranged for emergent dialysis. His initial potassium, mind you, after initial shifting, was 9. His glucose was 1600 and his pH was 7.07, so extremely acidotic. His hospital care, he was admitted for type 1 diabetes with DKA, as well as methamphetamine abuse and gastroparesis. He underwent 4 days of treatment before he was discharged, and it was noted that this was his 3rd admission in the last 2 months for DKA and non-medication compliance. So he was stopped off his insulin pump because he's not a reliable patient to be on an insulin pump. We covered the DKA case last month, so I'm not going to spend as much time just because we recently covered it. But again, hyperglycemia, acidosis, and ketones released in the urine. Mortality is less than 1% these days because of advancements in treatment. And then the pathophysiology is that the normal process of insulin stopping this hyperglycemic event just doesn't happen. So more and more and more of the glucagon and the glucose coming from glycogen and muscle breakdown occur out of control, and there's no checks and balances for this. Oftentimes these patients are going to be lethargic, they're going to be tachypnic, they're going to be dry and hypotensive, and our management is IV fluids, at least if possible 2 IVs, manage electrolyte abnormalities. Not everybody is going to be hyperkalemic. Oftentimes they will be in renal failure because of the profound dehydration, and starting them on an insulin drip at the hospital and ICU management. This patient also had the added complexity of hyperkalemia, and as a reminder, hyperkalemia is greater than 5, that usually people don't develop symptoms until they're more above 6.5, and that these symptoms can be non-specific, such as weakness, fatigue, syncope, or palpitations. And it's not so much about the number, it's about how long it took them to get there. So our end-stage renal disease dialysis patients can live in a hyperkalemic range and really be asymptomatic and only be found incidentally. And then treatment is what happened. So this is our protocols here. calcium gluconate, 1 gram bicarb, 1 milliequivalent per kilogram, and albuterol with initiation of 5 and consideration of continuous. If you find that you might be in a prolonged transport, that you are well within your means to call medical control to talk about redosing or changing some of that initial management to aggressively manage these patients. Some of the things that, I had this conversation with the medic for this call, but the calcium gluconate equivalent dose to calcium chloride is 3 grams of calcium gluconate to 1 gram of calcium chloride. So but consideration of adding additional calcium. And remember, calcium doesn't do anything about shifting potassium. It only stabilizes the cardiac membrane so you don't deteriorate into sine waves or asystole or VTAC. And bicarb and albuterol are where we might have more of a effective role here. And oftentimes in the hospital setting, if we're not just we're repeating EKGs, looking at QRS and looking for narrowing of the QRS as the goal. Any questions? All right, move on. We're doing good on time. So third case is a 74-year-old male. What I mentioned about the second case is that this was the second case was a really sick. So I didn't mention in the QA part of things. The second, because I didn't review that case, but the second case really showed persistence on our EMS crews to recognize this patient is critically ill and to try their best to initiate assessment and transport and treatment. And then recognizing that the 12 lead was concerning for a significant medical condition. So going on to the third case, 74-year-old male, chief complaint of shortness of breath, living at a nursing home, I believe. PPE usage was appropriate with the HEPA mask, gloves, and eye protection. He was found to be awake. His airway was open, but he was in respiratory distress. He looked ill in regards to his skin assessment with pale cold extremities, and a pulse was present. And vital signs were obtained at the first contact with this patient, noted to have a normal heart rate, a normal blood pressure, a respiratory rate of 26, a GCS of 14, and an SpO2 of 39%. Past medical history is that this patient has a history of coronary artery disease, heart failure, diabetes, chronic kidney disease, hyperlipidemia, and dementia. And the information regarding this patient is that they arrived to the nursing home staff attending to this patient on the floor. Apparently, he started to have these symptoms after dinner, and I believe this call was around 11 p.m., so a couple hours after dinner. And he had vomited, he had syncopated, staff had assisted him to the ground, and he was awake at that point, but being kind of propped up by staff. And that his code status was that he was a limited intervention DNR. So CPAP was placed on him within a minute of contact. His SATs went up to 66%. A 12 lead was obtained at 13 minutes, which didn't show tachycardia, makes you suspicious for possibly having beta blockers on board, or if there's a heart block, but also concerning in the sense that he has what appears to be some ST elevation, possibly in lead V2 and V3 and possibly V4, but there's a lot of artifact. So this EKG was repeated and less artifact, more concerning for a possible STEMI. So crews got him expedited to be a STEMI activation in the field. Second set of vital signs showed that his SATs now are 83%. He's a little bit more hypertensive, still tachypnic. There was marked difficulty in getting an IV started on him, so I believe that he had 3 missed IVs. until 18 minutes after patient contact, where peripheral IV could be established and transport was initiated. Attempts to place a second IV were unsuccessful, and repeat vital signs were obtained en route. So this is a very complex patient that presents with shortness of breath and volume overload or heart failure, found to have a STEMI, and having syncopal episodes, likely not related to hypotension, but likely related to his respiratory failure. Crews mentioned that they did not give this patient aspirin or nitro, despite his 12 lead, because of the fact that they weren't, he was borderline, it sounds like, on CPAP, that they weren't sure that he would tolerate CPAP very long before becoming too obtunded. So they withheld aspirin and nitro and documented appropriately doing so. The 12 lead was obtained greater than 10 minutes from patient contact, which our goal is to have it done 90% of the time within 10 minutes. But I believe that this is an extenuating circumstance given the patient's airway and breathing issues. So 12 lead upon arrival at the hospital is indicated with this image here. You can see more better tracing on this 12 lead in what does appear to be ST elevation in the anteroseptal leads. Cardiology was previously activated because of the STEMI alert in the field. When they got to the patient's side, they felt that the ST elevation was attributed to an apical aneurysm, so they downgraded him from being a STEMI alert. The patient remained on BiPAP, and during his BiPAP ER management, he started having rectal bleeding, pretty profound from what my colleague was mentioning. So the patient was medically managed. Anticoagulation was not initiated because of the fact that he was also suffering acute blood loss anemia from a GI bleed. And in the hospital, he was admitted for an NSTEMI as well as respiratory failure secondary to his NSTEMI. He also had a known history of heart failure with an EF of 20%, so really very little room for him to suffer any additional insults to his heart. He also was determined to have aspiration pneumonia, shock, both most likely at this point cardiogenic, but also potentially hemorrhagic. And he was, in addition, he had hypothermia and hyponatremia. His son was contacted, and he agreed with the previous assessment of the patient being a limited DNR, and felt that this patient would not want would not want any heroic measures, so he made him comfort measures, and the patient passed away on hospital day 1. So just a little bit of a reminder of our protocols for STEMI and CPAP. Really, in the interest of time, I'm not going to go over every part of this. I usually don't either way anyway, but so really the complicating part is that this patient is, from the documentation, pretty profoundly sick and needs constant reassessment on CPAP to make sure that he doesn't end up aspirating because he can't protect his airway. The crews did a great job of documenting that they were watching him closely, and that because of his respiratory status and his mental status had kept him from being a candidate for other medical management, and in hindsight ended up being appropriate, especially since the patient was also having a GI bleed. And that I think the part here for the STEMI on the right side is that, as a reminder, that if you are just looking at AVR if you're looking at just AVR for ST elevation, that we're not calling these STEMIs, we're calling these as concerning to the hospital, and letting the ER doc discuss it with the cardiologist to determine if they really do want to activate it as a STEMI or not.
Jackie, let me interject here just a moment. This was this was part of my lecture this month, the AVR, isolated elevation AVR in as not being a STEMI, but very concerning for acute coronary syndrome. We had within a week of doing the lecture, we had a perfect case that was perfectly managed in the field. They did not call it a STEMI. They called it, they sent in they sent the 12 lead in that this was ST elevation in V4R with diffuse ST depression in other leads. That patient was brought in and treated as acute coronary syndrome, was seen immediately, the cardiologist was consulted. He said, we will ultimately take this patient to the cath lab very, very quickly. Unfortunately, our cath lab was tied up. All cath labs were tied up at that moment. The patient was transferred to Kaiser, which was her insuring, and she went to the cath lab within an hour of arriving and was found to have diffuse coronary artery disease, which could not be stented, and she was taken urgently to surgery and received a 4-vessel bypass, and was doing quite well after the surgery. This is very typical of these cases, that if they turn out to be acute coronary syndrome, they're usually not. So usually related to a medical problem such as sepsis. But if they turn out to actually have acute coronary disease, it almost invariably is not able to be stented. They need to go to cardiac surgery. So this is well done. It was well handled. We don't treat them as a STEMI, but we treat them as an urgent evaluation for whatever is the underlying cause.
Perfect. And does anybody have any questions regarding this case? I put this case in here because of Dr. Whitwer's PCEP STEMI lecture this month, and this was as I was looking through our first pass, looking at all of our STEMIs for the month, I was just impressed with the complexity of this patient and the crew's management. So case 4 is a twofer as well. 78-year-old female, complaining of chest pain. PPE usage is appropriate. Patient's awake, airways open, pulse is present. She had vital signs done prior to transporting crew's arrival, notable for tachycardia of 104 and SATs of 90%. Her past medical history is that she had coronary artery disease with a stent placed. She also had a history of hypertension and GERD. The patient had complained of intermittent chest pain since the night prior. This is about 24 hours after she presented, 24 hours after onset of symptoms. She told EMS that her chest pain was gone. There was some discussion. She wasn't exactly sure she should even go to the hospital at this point since her chest pain had resolved. But she did have some shortness of breath with communicating, and she was given some nitroglycerin. So patient agreed to get a 12 lead, which lo and behold shows elevation in AVR and diffuse ST changes, depression. Hold on, I think I need to get there. There you go. So aspirin was given to this patient. SATs again were noted to be on the low end of normal at 92%, and she was in the back of the ambulance. They hadn't initiated transport when she had told them, I think I'm going to pass out. They looked at her and noted that she was in cardiac arrest. She went into VFib. They defibrillated her 200 joules, and this is the ROSC 12 lead. So she's an AFib with RVR with, again, the same ST changes noted from the previous one. Hopefully, yeah, good. She was, I believe it was 1 or 2 rounds. I think it was actually 1 round of ACLS where they were able to get Ross back, and they called medical control because they had not initiated transport yet. And although they had gotten Ross, the patient was pretty obtunded. They were thinking about moving forward with RSIing her because they were having to ventilate her with a bag valve mask and she wasn't protecting her airway. But her daughter, who was outside of the ambulance, had stated that no, don't intubate her, she's a DNI. So the crews called in the midst of their resuscitation asking some guidance on what to do with this patient without proper paperwork, but with a family member who, for all intents and purposes, should be looking out for the best interest of her mom. And they had mentioned that the patient, although she wasn't protecting her airway, that she was not difficult to ventilate, and that they were able to ventilate her appropriately with a bag valve mask and BLS maneuvers only. So given this information, the recommendation was for her to continue to be ventilated with BLS measures, in that if it becomes an issue, either she starts vomiting, you can't ventilate her, she's still hypoxic, or she arrests again, to contact base for guidance on what to do next. Luckily for this patient's case, she became more and more alert. EMS had actually, when they called and discussed this 12 lead, they discussed it with me. And although they didn't call it a STEMI alert, there was some confusion at the hospital side of what we had to call it. So it was termed STEMI alert despite it being ST elevation and AVR. They also, EMS is calling, in addition to the code status, to what kind of activation this should be, and also because of the fact that they wanted to manage her AFib with RVR, but given her post-ROSC state, they were concerned that diltiazem would lead to profound hypotension and wanted guidance in regards to that. So overall, she got DILT. She was managed to optimize her blood pressure, and she had BLS measures for her airway. By the time she arrived to the hospital, she was awake. She was, I'd say, mostly alert. She was on a non-rebreather mask, and she had mostly only complained of shortness of breath at that point. So a really, sick patient who has some wrenches in her care on how much she wants done, and that we have to contact medical control for do we proceed without without an invasive intervention, and how much do we aggressively manage what we're seeing in front of us right now in regards to her airway and her rhythm.
Where did she come from?
Where's she come from?
Yeah, I mean, it looks like your times look like it was a really long time.
I don't think that she was that far to, I think, so she got transported at 36 minutes and she arrived 58 minutes. My understanding is that she had a scene time because they were trying to figure out before moving if she needed to be RSI'd. I don't know exactly where she came from geographically. And, if there's anybody that's in attendance that wants to say where she's from. So in the emergency room, interventional cardiology came down because of the STEMI activation, and they elected for medical management specifically because of the fact that she was a known vasculopath, and she had a previous heart cath that showed a completely occluded RCA. And even at that time, the patient had elected to just do conservative management and did not want to have a cath for a stent or any other aggressive maneuvers. So her daughter arrived shortly after the patient arrived. The patient was placed on BiPAP, and the patient and the daughter both agreed that not only is she a DNI, but she's also a DNR. Chest X-ray, the DNR was determined after, it was not previously it was after she arrived to the hospital. in speaking with her mom and the patient's goals of care, she didn't want to be resuscitated if she arrested again. So the chest x-ray that she got, I forgot to put it in. I'm going to see if I can quickly get it here. But anyway, the chest x-ray showed, I don't think I can put in, maybe. So that's her chest x-ray. So she's got infiltrates on the right side, not so much on the left, concerning for possible infectious etiology for her shortness of breath. So her COVID-19 was negative. She was treated for pneumonia, sepsis, and STEMI shock, started on pressors and started on antibiotics in addition. During the hospital course, she had worsening shock, refractory to 2 or 3 pressors. They felt that her shock was secondary to cardiac sepsis, cardiogenic shock and sepsis. So at that point, since she was not responding to pressors and antibiotics, they elected to make her comfort measures, and she passed away on hospital day 3. The next case is a 49-year-old female that EMS was contacted for unconscious party. Initial PPE usage was maximum, so no issues or concerns there. The patient was unresponsive to painful stimuli. Her airway was open, but she wasn't protecting. And per the medic I spoke to, that she was the deepest yellow that he had ever seen. So jaundice, she was warm, she was dry in regards to mucous membranes, and she had a pulse. Vital signs initially notable for tachycardia rate of 111, hypertension at 157 over 100, a GCS of 4, and a blood glucose of elevated, but not speaking to her obtunded state. Her past medical history is that she has diabetes and end-stage liver disease, and that her husband had seen her the night prior. He said he found her this morning on the floor, unresponsive, and that she was feeling ill for the last 3 days. When he was asked to elaborate, he had reported that she was nauseated, she was lethargic, and she had taken very little in, and that she was seen about a week and a half earlier for liver issues at the hospital. So within 5 minutes of patient contact, she was placed on a non-rebreather. A peripheral IV was attempted but unsuccessful, but an IO was able to be established. Vital signs are the ones mentioned in the previous slide. She got 40 milligrams of lidocaine for that IO, and she was RSI'd. But before she was RSI'd, the husband had, I don't think I put it, no, I didn't. So before she was RSI'd, the husband had stated that she is a do not resuscitate, but he did not have any paperwork to support that decision. So the crews moved forward with RSIing her. She got etomidate and succinylcholine. For any of you guys that get my case reviews with a unresponsive concern for possible liver or kidney disease, I highly suggest to use rocuronium in lieu of succinylcholine. They were able to intubate her on first pass. They used DL, and they initiated transport 19 minutes after patient contact. Repeat vital signs showed that she's no longer tachycardic. Her pressures are about the same, and they initiate post-intubation sedation with fentanyl and Versed. They obtain a 12 lead and repeat her vital signs and give her another dose of post-intubation sedation. So the crews did a really thorough job on assessing altered mental status with physical exam, ocular assessment, blood glucose, neurological status. They RSI'd her with first pass success, although no bougie was documented, and the PPE usage was appropriate and sedation afterwards was appropriate as well. So where we could do better, and that's why we have these 2 slides, or these 2 cases in this case 4, is when a patient has code advanced directives that are to not be a full code, but they don't have either the paperwork to support it, or they're unresponsive and it's somebody else saying that they have advanced directives. Our protocol states that if you are ever in question in these situations, to call medical control. And make sure you document a HEPA filter. So in the emergency room, the husband arrived with the same story of DNR, DNI, which was decided on previously when she had a normal mental status. She was recently admitted, but they did not go over her code status. Unfortunately, that was a miss. And so they had to go off of the fact that the patient was offered a liver transplant previously and she had declined, and the husband saying that she's DNR, DNI. So given the fact that she is end-stage liver disease, they extubated her, believing that the husband had the patient's best wishes, interest, or best, in interest. So she was admitted to hospice care for decompensated heart failure. Her ammonia level was 178, and she was also hypokalemic. She passed away on hospital day 4. So that's our protocol, and a reminder to everybody that, yes, it's ideal for the patient to have appropriate documentation indicating that they have been educated about what their advanced directive wishes are, and that they have filled out paperwork with a medical expert to ensure that they'll have their wishes met. But in the event that they do not have, so under guidelines on the right side, when the patient's family, friends, or nursing home personnel state that this patient is to not be resuscitated, BLS and try to find the paperwork that they are mentioning. And if you can't find the paperwork, call medical control. All right, that is all the cases I have for you guys and gals. Any questions?
Great cases.
Yeah, some great cases handled by, some great complex cases handled by our crews.
Yep.
All right, well, thank you for your guys' time. If there's no questions, as always, looking for good cases, great cases to present for case reviews. So if you want some of your cases or some cases you'd like some to be presented, send that to the MPD's office.
Thanks, Dr. Gadbois. Those were, yeah, that was very, very well done.
Thank you.